little bit about the organization that they work with, and then we'll get started.
Happy to start. Hi, I'm Crystal Mulder. I'm a consultant with AM Consulting, and we are a rather large firm. I'm in the health and benefits practice in the Los Angeles office, and I have the pleasure of working with clients and helping them set strategies relative to employee benefits, especially healthcare. And an area of expertise of mine, I'm one of a few subject matter experts in the country that actually specializes in helping clients create and design and implement wellness programs. So this topic today is just to be here today and to be part of this panel is just, it's very exciting. And it's terrific that Pepperdine had the foresight to really do something fairly quickly with healthcare reform, obviously putting healthcare and the concerns relative to healthcare from all sides. I mean, it's a 360 review. It's a 360 question about healthcare as to impacts employers, it impacts employees, it impacts people in general. This is just a terrifically relevant and timely topic to be talking about, and then of course to couple that with Mr. Murdock's conversation about wellness sort of brings both things together. So pleased to be here. Thank you.
I'm Troy Medley. I'm the CEO of PersonalCare Physicians, and we are the leading provider of concierge family practice services in Southern California. We're trying to fix the way healthcare is practiced and delivered, and doing that by taking physicians out of the traditional rat race factory approach to medicine, where they have 3,000 to 4,000 patients, and they have to see 30 to 40 of them a day. Our physicians only see 350 patients. They see 5 to 6 a day. They work with them. In fact, they don't work with them, they partner with them to develop a health and wellness plan where we figure out exactly what they should be eating, how they should be exercising, and our new facility will even be able to then help them exercise by working out with our exercise physiologists and our trainers. So our desired outcome when partnering with a patient is to keep them from getting sick in the first place, which is ironically a revolutionary concept. And it goes against the grain, and it goes against the entire system. So that's what we look to do and capitalize on the emerging market in that area.
My name's Denny Weinberg. I don't have any current bio. My bio is what I used to do. I had a 20-year career as one of the co-founders of WellPoint, and also was the partner with David Murdock in the design of this site.
Thanks, Denny. All right, well, I wanted to get things going by asking the panelists to reflect a bit on the past. So thinking back 10 years ago at the turn of the century, what did the industry look like at that point in time? And then compare and contrast that with the year 2010. So we can start, Crystal.
I'm happy to start. I think when we look back at employee benefits, and specifically from the consulting side, as we've worked with a number of different employers. Benefits, years ago, even 10 years ago, folks weren't as concerned about the cost, and each benefit was typically commoditized and separate. So we looked at healthcare separately. We looked at dental, we looked at various types of benefits separately. And I think what's different about where we're at today is, one, suddenly healthcare costs are have risen so quickly that folks are starting to realize, okay, even though employee benefits or health insurance is something that I need from an employer standpoint to attract and retain and to be able to hire folks into the organization, I really need to focus, and that's something I have to offer. I have to now focus on cost. And frankly, healthcare or health benefits are not an isolated review. We really look at this from an integrated standpoint, whereby we realize that the costs that drive healthcare are also costs that drive, potentially costs that drive, the things that drive healthcare cost are things that also drive dental costs, that drive disability costs, that drive productivity costs, that drive life insurance claims. These things, workers' comp claims, potentially. And what I mean by that is if you have an unhealthy employee can cost you an awful lot of money. So I think that in the past, we really never looked, even 10 years ago, really never looked at the fact that there's a lot of connectivity between these issues, and very, very relevant today. And I have one of my colleagues here with me who I work with, and she can also attest to the fact that many of our clients are really asking us to look at things from a much more integrated standpoint, because it's a domino effect and it's very interwoven. So significant change from what we've seen even in the last 5 or 10 years.
Well, 10 years ago, concierge medicine didn't exist. The first concierge family practice to open in Southern California was in 2003. And that was pretty much an outgrowth of a lot of the pressure that was building up for doctors. In the 90s, there were a lot of public management companies that rushed in. They bought physician practices, and they used stock. And so these doctors who had spent 20, 30 years building a business, in the rush to cash in, sold their businesses. The stock went up, the stock went down, and in about 2000, all these folks were licking their wounds, and they were trying to figure out what they were going to do next. And they could go back and try to build a 4,000 patient practice. And when you're 55 and starting over, it's a little difficult. Or they could try to figure something else out. And out of economic tragedy, there is usually economic innovation. And so one of the outgrowths of all of that was people started to say, is there a better way to practice medicine? And all of that was just under the surface about 10 years ago. And right now, there are a lot of large concierge practices. In fact, the largest national company, MDVIP, was just purchased by Procter & Gamble for an undisclosed sum, which means it was large. So you're going to see this type of practice really grow over the next decade.
If I look back on the environment 10 years ago for the managed care companies and the insurers and try and compare that to where I think things will be 5 years out, I think there's just been a radical shift in the market. Maybe I can talk about 4 or 5 dynamics that are dramatically different. First of all, the managed care industry is an old industry. This really began working in the mid-'80s when most of the states passed laws that allowed selective contracting between insurance companies and physicians. This model of building networks and trying to negotiate discounts and trying to squeeze some notion of unnecessary care out of the system is almost a 25-year-old, 30-year-old model. Most life cycles of businesses are shorter than that, and one of the dilemmas as you look forward, and we see problems around the edges really that are at least 10 years old that were beginning to show up 10 years ago. But as I look 5 years out, I really think it's the end of managed care as we know it today. And it probably means that the role of intermediaries is going to be greatly diminished. So one of the differences is a life cycle question. 10 years ago, there was still some room for the industry to progress. 5 years from now, I think it's probably over. There were great moves from the 10 years ago. There was a great movement towards consumerism. The insurers really gave up pursuing a lower cost management option for something that would be more comfortable for American consumers and businesses. And so the system opted for very open-ended access between patients and the medical care delivery system, and the insurers were fine with that. It's not a very manageable system, so when you hear managed care companies talk about managing care, it's definitely a limited role they can play because the system is an open system. 5 years from now, I think that's gonna change dramatically, and a lot of it will be because some of the other dynamics that are gonna be driven by regulation. But you had a highly consumer-oriented industry 10 years ago, and I think we'll see a highly unconsumer, more commodity-related system 5 years from now. I would imagine that healthcare insurance will have very, very thin margins. There will be very little to differentiate one product from another, one company from another, and that couldn't be more different than how managed care companies operated 10 years ago. There was a lot of consolidation 10 years ago that allowed profits to be generated. Managed care companies were gobbling up other managed care companies. Hospitals were buying up hospitals. And you were seeing it in some of the ancillary parts of the care delivery system as well. And that actually probably created 10 years of viability, of financial viability for a lot of these companies. That's largely over, even to the extent there's more consolidation take place. There's no financial impetus for it to happen. There's no good returns on those kinds of things. So that's another big difference. And then finally, in terms of regulation, insurers have been historically, since the beginning of insurance, even before health insurance, were regulated by states. States were largely there to make sure that insurance companies remained solvent, didn't fail. That allowed a great deal of freedom in terms of customizing insurance coverages for employers and for individuals. 10 years ago, that was still, in most of the United States, that was still somewhat the case. It was getting more and more difficult. But state regulators were more and more feeling like they had an obligation to control products and the experiences of patients. And so 10 years ago, insurers were really beginning to see states intrude on offerings, mandate certain kinds of coverages, eliminate certain kinds of freedom and flexibility, most of which probably generated higher cost for patients. But boy, now we're looking at light speed. For the first time, the federal government is going to probably overtake the states. May end up taking over the state's responsibility in total, 5 years from now. So it'll be a highly regulated market. And the result of that just forces more commoditization. As I look at the federal reforms and try and imagine what the role of state regulators will be for insurance companies, I picture very commoditized products, 4 or 5 health plans that are identical, depending, undifferentiated from one company to another, very thin margins, very good chance that insurance companies will lose money on some of those. It'll be not a growth and profit-based business, but much more of a commodity. And so this time frame, 10 years from now to 5 years from now, probably covers from the good times to the terrible times for health insurance.
Should we sell all our stock in insurers?
I don't know any.
All right, so Danny started answering my next question, which was if you could put on your forecasting cap, what do you see 5 years from now? So I give the other panelists a chance to jump in, and in particular, in light of legislation, healthcare legislation, and those issues.
Well, I'll talk about the healthcare delivery side. I think that in 5 years, the healthcare system will be a lot like the education system. You're going to have a public system that is subsidized by everybody in here, tax dollars. Costs will continue to go up. Outcomes will continue to go down. You'll continuously hear cries from those in charge that if they just had more money, if they just had more time, and things will continue to get worse. That's the positive. That's the negative. The positive is it's great for somebody in my business because it's created a market for people just like folks that want to send their kids to private school will want to pay a little bit more and invest in a private physician, somebody that can give them the time and attention that they need. It just is what is.
I want to extend a little bit on what Denny said, which is a couple of things I think that we're looking at. Number one, truly, and I think Anthem, the issue with Anthem and the fact that the federal government came in on the individual increase that California was going to be subject to on individual policies with Anthem, and you saw the speed at which the federal government and the Secretary of Health and Human Services came in and weighed in on that and asked for really called into question the increase and asked for answers and folks to have to speak and justify this at a federal standpoint exactly talks to, I think what Denny said, which is we are going to see, at least I strongly believe, in my humble opinion, we are going to see significant federal oversight and eradication of some of these the state-by-state insurance regulations. That frees up, that'll change a lot of how business is transacted in the healthcare arena. Also along the lines of the things that with healthcare reform as it's gone in, with the very thin margins, with the expectation that a certain amount of dollars, premium dollars, have to be spent on healthcare delivery, and a minimum amount spent on profit and administration, et cetera. I think that we're going to see healthcare companies become much more receptive to, instead of being sick care companies, which traditionally health delivery systems have treated people, you go to the doctor when you're sick. That's generally how folks have sought healthcare. I think we're seeing folks, at least in our experience, in my experience, with the Big Four, with Anthem and Kaiser, and plus Kaiser, with Anthem, with Cigna, with Aetna, with United Healthcare, starting to show much more receptivity or reception to focusing on wellness and focusing on prevention and trying to get folks from using the emergency room as a primary treating source. That is extremely expensive business model. So really the focus of trying to spend dollars more wisely from an insurance standpoint, the dollars more wisely spent is going to be on the front end. If you have folks that are healthier and you're catching these folks at a time, I mean, if they're going and they're doing routine screenings and they're doing the things they're taking preventative action and they're eating healthier, they're doing those types of things, then, the trickle down it helps both the person, the individual, but also clearly helps the healthcare delivery system and especially not the delivery system per se, but definitely the insurance piece of this. So.
Well, can I second that?
Yeah.
I mean, we're now working with multiple small, medium, and large companies that are trying to put together very comprehensive wellness plans for their employees so that they can have an annual physical, so that they can have exercise and diet plans, so that they can keep them from getting sick. Because the cost to a company that provides health care, if they have an unhealthy population, is dramatic. I mean, it's astronomical, and it's going to continue to grow. So the companies are saying it's in our best interest to invest in keeping the people that work for us from getting sick in the first place. Not to mention the fact that they get higher productivity while they're there. And I believe it's 2014, there's a large amount of money that is going to be available to companies, and I believe grants, so that they can invest in these things for their employees.
I suspect that, if we go back to the early 90s, there was a contest inside the industry about what care delivery model would be more lasting. There were advocates that saw that the closed system HMO was the only way to really control costs, and there were other advocates that were trying to follow what consumers were more likely to follow. And when I remember those days where we were watching the attempt to develop closed systems, closed panel HMOs around the United States, and they succeeded in some places and sort of fell apart in other places. What kept those organizations from working was the complexity associated with the insurance side of the business. Now, if I look out 5 years, there's not going to be all that complexity anymore. Most of this will have been set in federal law. There will be very little, there are not going to be questions about who you select or who you allow to buy your plan. Anybody can basically enroll in anything, which makes me believe we're going to see a resurgence of the multi-specialty closed systems again that are provider controlled, and that these companies will maybe successfully be able to offer the financing or the insurance mechanism themselves, as some of them were successful in doing in the early 90s. I guess the Twin Cities models still is probably a part of the country that still operates that way. So that's one of the big things that I see, is that probably well-organized physician groups, maybe owned by hospitals in some cases, maybe through some affiliations, will probably end up being able to operate without any third-party insurer at all in 5 years from now.
We've seen, just one quick comment on this, I've personally seen an increase in the number of healthcare clients that I have and that we have in our business, and I suspect all of my colleagues in other firms are also seeing this, but we have many healthcare or provider groups that are spinning off of larger groups or that are trying to form because they feel that there's a way to deliver service now because of the vehicle of healthcare reform that in a way that they've never been able to do it before. And there's an incredible demand probably for these types of closed network or provider groups to come out and offer these types of services, even in sort of a specialty or in a boutique area. So just tremendous change relative to the healthcare market, and I think the entire spectrum from first of all who's insured, which is going to be everybody, to how services are delivered, to how they're paid for, to who's funding it, to the plan designs and the things that you're talking about. And I completely agree. I think one of the challenges that's probably created some of the healthcare cost issues that we see today is that employers allow all sorts of different plan designs, and frankly PPO options, which are wonderful, are costly. And really and truly at the end of the day, to have employer-sponsored healthcare plans, if in fact this is the route that we see, which we don't know. I mean, honestly, when I look in the crystal ball 5-10 years from now, I'm not quite sure what that's going to look like, although I tend to agree with you, Troy, that there's going to be a baseline offering with some type of a top-up offering where people want to be able to jump the queue, if you will, which is what you see in other countries. I think that we're going to see significant streamlining of a lot of the things that are offered, that you're not going to see things offered in the future that we see offered today in terms of all sorts of wild choice. In network and out of network and all this great stuff. I mean, I think that just becomes a thing of the past, and I think it becomes a thing of the past fairly quickly. So, we as consumers, we as employers, we as anybody who deals with healthcare situations are going to see very limited commoditized and very limited, I think, offerings and fairly restrictive offerings. So.
There's going to be one other major change. Who in here has a family practice doctor that you go see? Anyone?
Family, yeah.
Are they fewer than 5 or 6 doctors in the building? Or is it 30, 40, 50 doctors?
Fewer than 5 or 6?
Fewer than 5? Okay, that's going away.
It's going away.
Because they cannot financially survive.
Yeah.
They have to pool. You're absolutely right. Hospitals are going to either directly, and in states where they can't directly, through some sort of affiliation, financially support the physicians so that they can have they've got a couple $100,000 worth of student loan debt they got to pay off. Plus, they got to keep the wife happy. That's not going to happen.
Or the husband.
Or the husband.
Well, more and more the husband.
I think of my partners. I got to keep the wife happy.
Okay.
So this is going to be more change in the next 5 years than this industry's probably seen in 30.
Yeah, it's very disruptive.
40, 50 since Medicare came in.
I think the other thing is, of course, there's a $500 billion that's going to come out of the system somewhere over the next few years. My guess is there's going to be a massive cut by Medicare in specialist reimbursement. And the role of and my guess is, as this administration has, and this Congress seems to have done with everybody who makes money, the $1 million, the physicians making $500,000 or $1 million a year will be villainized as well, and viewed as if you're delivering care, you shouldn't be able to make a whole lot of money at that. They'll effectively do that as well, and we'll see a radical change in the role of specialist care. Now, I don't think there's going to be a big increase in the reimbursement for primary care. I think what's going to happen is most of that primary care is not going to come from physicians. It's going to come from others.
Others,
Yeah.
yeah.
Nurse
Are there any
practitioners.
just curious? Are there any doctors? Any practicing physicians?
No, they're still at work seeing patients.
With their 4,000 person panel.
There was a question
we have some
related to the
questions.
issue.
I saw your hand.
Oh, earlier, you guys were talking about, I think, disease management, wellness programs and all that. Isn't in this healthcare reform, the medical loss ratios are going to be trimmed? I think for large group plans, 85%, and below that in individuals, 80%. And isn't there a question of whether disease management, wellness plans, and all these wonderful things that are going to work or that do work might not be included in the claims, that 80 or 85% bucket? And if that's the case, it would go in the 50% bucket. And what's the incentive? I mean, maybe long-term for insurance carriers, it makes a lot of sense for disease management, wellness, and all these wonderful things. And where's the money going to come from if it's in that 15 or 20% bucket?
You know, it's an excellent question, and I don't think that we've heard both sides. So we've heard, yes, in fact, it's probably going to be baked into that 80-85% loss ratio. And for those of you that don't know what a loss ratio is, literally, if you think, if I pay you $1, you're the insurance company, and I pay you $1, how much money do you spend on actual claims, on rendering services? So 80 or 85% is 80 cents or 85 cents on the dollar is what is expected through this healthcare legislation to be spent on these medical services. The additional 20 or 15%, depending, has to do with administration and various profit and all this other jazz. I think your point's well taken. I think we're still waiting for, in fact, I know that we are still waiting for guidance on this, but there's an awful lot of conversation about doing what's necessary to incent the right behaviors from a delivery standpoint, because you want to have wellness and disease management and these types of things as an incentive. And if it's structured in such a way that it's part of that 80 or 85%, it becomes a disincentive potentially. So it remains to be seen. It's certainly a topic of conversation, and certainly something that we know, that I know that my colleagues that work in the healthcare industry, in the insurance side or in the health carrier side, are extremely concerned about the ruling or the guidance that'll probably come down on that. Point well taken, very well taken.
And companies pay groups like mine outside of insurance. I mean, they pay us like another consultant in hard currency to keep their employees from getting sick, because when they compare what it's going to cost them over here, they figure they're going to spend less to keep people healthy than in trying to figure out how to work through the insurance system. Because I've been running a healthcare company for 2 years now, and I still barely understand everything. I mean, and as soon as you get it figured out, they change everything. So
you're saying like the large employers are paying on the side?
Yes, and there's going to be grant money available starting in 2014 for the small and medium-sized companies, where the government will take money and say, okay, well, we're not going to run this through insurance, but here's some cash, go in and have a wellness program put together. Now, we all know where that money comes from. It's coming from the same source.
Isn't that, I mean, these are layers. I mean, the system now is so unsustainable and so expensive, and now we're talking about concierge where you have to have insurance for your catastrophic, for your drugs, for your specialists, and everything else. Now I'm going to have, whether it's it all comes from somewhere, whether it's the government giving it to us and charging us in taxes and less take-home pay, or if I'm a business owner and I'm going to all of a sudden pay my employees' insurance premium, and now I'm going to pay for a disease management program, or I should say, and my employees have to pay on their own, or maybe I'm going to have to pay for on my own, for them to go get primary care, because no internists accept any insurance do this concierge business. I lost my doctor, and my business partner lost his doctor in the last year because both of our internists went concierge. So this is layer upon layer upon layer. How does that bring down costs?
It's not going to.
Well,
the entire system will eventually, this is my personal feeling,
right.
It's going to implode, and a new system will have to be built on top of it. Nobody in Washington or in Sacramento is willing to say, wow, we got ourselves a mess. So they try to fix the mess, and then they layer it, and the house of cards, sooner or later, will fall down. In the meantime, the person that loses is the patient.
Right.
And
two dilemmas that you've got here, though, really and truly. I mean, first and foremost, well, many dilemmas, but first and foremost, from the healthcare standpoint, I agree. I mean, the bottom line is unless something changes, we're insignificant. Unless there are significant changes to the costing of this, we're in trouble. But you'll notice that healthcare reform, the primary objective, and I mean, here's me, and this, if you knew me, you'd know this is exactly where I'm going to go. I'm at my kitchen table here, folks. Let's get honest. Let me roll up my sleeves, and tell you what I think. The healthcare reform primarily was meant to give insurance to cover everybody, because we've got uninsured folks. That said, you'll notice very specifically there are few things, if any, to address the rising cost of healthcare. Okay? So that is a huge challenge that we are now faced with. So now we've got virtually everybody covered and no mechanism to control cost. Out of that, you get boutique businesses that are, because there's no vehicle for people to try to address them through traditional means today, such as a concierge type service, such as wellness companies. There are wellness companies all over the place that come out and they specialize in implementing wellness programs. You know, our perspective, at least mine, as one of the folks that deals with this all the time, is, okay, hold on a second here. Why would we want the dollars, if we're going to still have traditional health insurance, if we're going to still have an Aetna, a Kaiser, or whatever, why wouldn't you want the dollars to be with the health plan? Because hopefully, if I'm as an employer spending money on implementing wellness, I want the health plan to really help me with that process. Two, why do I want the data outside of the health plan in another place? But many of these wellness companies have sprung up, and I don't disagree, I think there's a value for it, but they've sprung up because the health plans are not addressing the fundamental issue of wellness and prevention. They haven't done a great job with that. It's not a core competency because, I'm sorry, I hate to go out, you know, I have a very nice gentleman sitting down the table from me here who's, you know, who is one of the co-founders of WellPoint. But, you know, with all due respect, I think that things have evolved to a point where we realize that the wellness and preventive aspect of things is just critically important. Somebody's got to do it. You wish the health plan would, and you hope that they're not being penalized through this new legislation to handle it.
It's a question over there.
You mentioned concierge services and everybody getting health care. Doesn't this create a two-tier system? Everybody that can't afford anything will get the public school system, and those people who are basically well off will be able to afford their private insurance. In my healthcare delivery course years ago, my professor was from Germany. He said socialized medicine, equally bad healthcare for all except those who can afford private. And that's where this is driving.
Right.
It smells of it, yeah.
And you know, to defend concierge medicine, it's not our fault the system's broken.
Well, you see an opportunity.
Yeah.
You see the need.
Well, why? So you want to know why I'm in concierge medicine? My wife is 25. She had something on her lip, and we continuously went to the doctor, and she didn't fit the profile because nobody 25 years old gets squamous cell carcinoma on their lip. So a year later, it had grown to about 1.25 centimeters, and I strongly encouraged the physician to make sure she had a biopsy. I don't think I could have done any more strongly without having the police called. She was in surgery a day and a half later. They had to take most of her lip away, including half of her chin, and we spent 1.5 years having things put back together. The system fails people outside the middle of the bell curve. So about 6 years later, I met my current physician who said, hey, listen, I hated what I was doing. I would see my patients at the grocery store and I didn't know who they were because I had to see so many of them. So I've started something new. I'm only going to see 300 people, and I'm going to do everything I can to keep those people and their family healthy. So at the time, I was an up-and-comer, but I wasn't making as much money as I am making today, but it was worth it to me to invest the money, which is about $200 to $300 a month, to have somebody that I knew I could call at 4 a.m. to protect my wife or my family. Now, should we all have that? Yes, we should. Will we all have that someday? I hope we will. But we can't just say because, did anybody here drive in here today in a BMW? Or Mercedes? Okay, I know you did. Well, not everybody can drive that, so you've got to give that away. I mean, does anybody send their kids to private school? Raise your hand if you send your kids to private school. Well, we're going to take that away from you because not everybody can have that. The people that are going to concierge physicians are the ones that are mostly supporting the bad system with their tax dollars. So the thing will correct itself, but it's going to take a hell of a lot of blood, sweat, and tears. And
there's an interesting...
I'm curious to hear his perspective.
Well, here's what I'd say. There's an interesting thing. If you look at the maturing of most of the European health systems, they're all two-class systems. And Europeans don't have a problem with two classes. It's very historic for them for many, many years. Historically, Americans didn't have a problem with multiple classes. We were kind of proud of, starting at the bottom, working our way up. But, the recent political reality is that social policy is being made before us, I think to the shock of a lot of Americans. And, you know, it's quite possible that it will be deemed illegal to have 2 classes of care. Now, that you can't, you know, you can almost imagine this current government and its point of view saying it's not fair to low-income Americans to have high-income Americans be able to spend their money and go to a better system. And so, you know, my fear in all of this is that, you know, we've got runaway politics that are capable of all kinds of insane things. And the current version of health reform, you know, quite possibly couldn't be the, you know, may not be the end game. There's many aspects of it that are going to be problematic in implementation. One very well may be that as many employers opt to pay penalties instead of providing insurance, right, and doctors drop out of the system and insurers drop out of the individual and small group market, all of which are very likely, that the correction may be that the government will say, well, now we're going to tell you what you got to do. If you're a doctor, because there's examples of this in Medicare. You know, you got to take Medicare. Here's what you accept. You can't charge more outside of it.
They've slid a Medicare poison pill in the new health care legislation to make it very difficult for somebody to opt out of the system.
You know, I'm upset because it seems like here in the panel, it's let's just lay down and let this happen to us. You know, you're saying most Americans out there don't want it to happen. So why isn't there an outcry for that? I'm looking forward to this.
In November.
I'm looking forward to this.
In November, go vote.
Exactly. I mean, that's what I want to hear more about, is what can be done there. I mean, is there light at the end of the tunnel, or are we going down this road? You know, some of our coworkers are actually looking at international health tourism. Going off to China and getting a bypass done for $8,000. Board certified, you know, UK or US doctors doing it, that's fine.
His business may very well be offshore in 5 years because it's the only place he'll be able to do what he's doing.
Why?
Yeah.
Actually, I wholly disagree, because then everybody in Congress would have to give up their concierge physician, which they're not willing to do.
No, please.
Good. We're in the business of providing medically necessary neuropsychological assessments to pediatric children. Okay? We spent all day trying to figure out how to get these parents coverage for these kids that have traumatic injuries. All day. Okay? The discussion that I'm listening to talks about the employer system, that not half the people in this country are not covered by public plans. Correct?
Yes.
Police, firemen, school teachers, government workers. We're not talking about that. So you have half the population that's already on a public plan. It's the employer, in my view, the employers are put in an awkward position now of having to fund some of these issues. And at no point have we talked about access to the patient. We've talked about the financial implications of physicians, folks like us, but we haven't talked about that patient who needs service.
Right. I just want to address one thing that you said, though. When you're talking about public folks, police and fire and these types of folks in public sector and government are also considered employers. Okay, so they.
Who's paying?
Taxpayer. Okay, tax dollars. Tax dollars. I'm sorry. Okay, I'm sorry.
So half the healthcare system today is publicly financed. Correct?
Yes, that's fair enough. That's a fair statement.
It's the taxpayers that are paying for it.
To make sure that we're all preaching from the same hymnal, or however you say that, we're not advocating for the current system. We're explaining it.
Right.
We don't think that it's a good system. That's why my doctors opted out of it. You're going to see more people opting out of it. I think that the only way you are going to stop this system that Denny described is by radically changing administrations. That is my opinion. So you can take it with a grain of salt.
You had mentioned, you asked them about 5 years out. How do you folks view just American entrepreneurialism, and that 10 years out, that actually the wellness groups are actually going to be more valued than the concierge doctors? In other words, you will have a little old lady that says, my son's going to be a wellness specialist, as opposed to a doctor, and that actually the valuation of what is going to happen in consumerism will actually create the new market niche, which then will bring back into the fold.
The problem with thinking about what sort of the natural course of market evolution is you assume a market that is free to move. We don't have a market that's free to move. We've had massive constraints that are going to be put on all aspects of the market as a result of federal health reform. And when you read through it, I've read through much of this law, there are so few degrees of freedom for things like what you're talking about that I think the natural evolution of the marketplace is going to be stifled. Now maybe, so if we rely on actions in Washington, D.C. to create opportunities for movement in the healthcare system, they're going to be very slow coming. I mean, Congress just doesn't act that quickly, and they just don't react that quickly, and they're very insensitive to what real Americans' issues are. They're interested in getting reelected. So it's a terrible place for market policy or market dynamics to be generated is out of our Congress.
Yeah, we will be vilified in the next 5 years. The concierge physicians will become the most, they'll become pariahs in the community, and that's because they have opted out of the system. And correct me if I'm wrong, the scariest thing about the new healthcare legislation is how incomplete it is.
Yeah.
There are multiple entries where it says that the Secretary of Health and Human Services has 1 year to fill in the blank. Yeah. So as we talk about what would happen in terms of dynamism, we don't even know what the rules are yet.
No, we don't. There's one particular word in healthcare reform that has, I think, everyone in quite the tizzy. There's one particular expression which has to do with grandfathering. Grandfathering may mean that what we believe it to mean, potentially, is that how the world is today can go ahead and continue on into tomorrow as long as no material changes are made to existing plans or coverages or what have you. That's a very difficult and precarious word because we're not quite sure if that truly means if I choose to add a concierge service as part of my medical offer, does that change my offering today? If I choose to go from fully insured to self-funded, does that change my offering today? If I choose to cover preventative medicine or prevention at 100%, does that change if my plan doesn't cover that today? So we're really stuck right now with a massive legislative situation that we're unable to interpret effectively. And this is no different than any other type of federal legislation we've seen come down previously. Let's go through Medicare ABCD, okay? Every time it comes out, there are years and years and years of pondering and thought about how to interpret or implement. So, and we're in no different situation now. It's just this is an extremely heated debate because this, unlike Medicare ABCD, this is personal because it touches every taxpayer. It touches every individual. To your point, this touches everybody. So now you've got all sorts of excitement because people are starting to realize, what does this mean to me? And it really is a very personal, of all the things that we have in this world, you just heard Mr. Murdock refer to this, your health is the only thing you can control, and we now have a very large legislative body telling us that they're probably going to start regulating what we can and can't do.
Can I ask a macro question now of the panel, or anybody in the room? It's my hypothesis that there's enough money in the system to meet many of the requirements of access, quality care, multiple tiered offerings, okay? It's the distribution of that money that's currently in the system that seems to be where the rub is. Do you agree there's enough money, $2.5 trillion, spent annually on healthcare, that that's a sufficient number of funds to provide the types of services that we're talking about?
Well, I'll tell you one thing that what you'd say, if you compare this to other places, it seems like a lot of money. But, if you look at in France, for example, a physician is not a highly compensated. That's not a highly compensated job. In equivalent dollars, you'd probably be talking about professionals that are delivering care in the United States making maybe a quarter of what they make today, to be equivalent. So, you know, is that enough money? I don't know. We've got an aging population. We've got a mindset that has been behavior modified into us for 2 or 3 generations, that whatever we want and whatever we define as health, we're entitled to.
Yeah.
And then we've got very highly compensated practitioners in highly sophisticated, technology-centered, you know, settings, you know, walking, you know, easily driving distance from any place in the United States. And so it's hard to imagine that you can box in how much it takes. Meanwhile, we've got $1 trillion that was just spent on the premise that $500 billion will be taken out of the bubble you're talking about. And
so isn't the question really boundaries, some boundaries, and the negotiation of what those boundaries are?
Yeah, I mean, if you take $500 billion out of the...
And/or access and/or reimbursement.
Yeah, if you take $500 billion out of the system today, which we have to do, and you redistribute it, lots and lots of people are going to have to do more work with less money. And probably some players in the market will disappear, which I believe they will happen.
Yeah. I mean, and some of the other issues that we're faced with are truly from, you know, from an agency such as Medicare. There's a ton of fraud and abuse in these systems today in terms of the reimbursements and the treatment. You know, there's stuff that you see out there, so there's dollars that are unregulated and unmanaged, and that in and of itself doesn't help this problem. So, you know, you've got money being leaked out. We don't have enough way to audit and manage that process, and by the same token, we're now, you know, faced with a very fixed situation in terms of how the expenditure that we're going to deal with. And this is it's troubling.
And there's one other point to make. We went on a tour of the Longevity Institute downstairs, where it's a fully functioning medical office where you can have state-of-the-art MRIs and scans. And if you need a mammogram, or if you have an issue, you want to be downstairs. And they have about $50 million of CapEx invested in the most state-of-the-art equipment. So the thing about healthcare is, when it happens to you, you want the best stuff. I know I do. Yeah. And the best stuff costs money. And it's the great thing about our healthcare system is we have the best stuff. Yeah. The thing is, we don't want to pay for it.
This is the absolute dilemma right here. We are a society of immediacy. We are a society of we're a successful bunch. We have a fair amount of income available to us, and it's absolutely true. If something goes wrong, I want the best care, and I don't care if the doctor's in the network. I'm going to the guy that I want, or the woman that I want, who I know is going to take care of me. And oh, but what do you mean it's not covered by my insurance? You know, so I mean, I think the fundamental, some of the fundamental challenges that we're faced with is the whole reason that healthcare, how healthcare was paid for way back in the day as an employer-sponsored benefit, was meant to be a basic coverage, and it's turned into a significant coverage with all sorts of crazy, you know, limits and things, and in-network and out-of-network and 3rd and 5th and 10th opinions and all this stuff that's paid for.
Doesn't that add a significant cost to the system that interferes with access and quality care?
But it doesn't,
we're talking about
but it doesn't necessarily mean that if it wasn't there, it would be less costly.
I also agree with you.
Might be better and more costly. You know, there's competing studies that, you know, there's competing findings on these studies about whether or not quality reduces cost. There's as much data that says better quality costs more than there is that says better quality saves money. So, you know, it's...
Right. I'm a believer in the free market and deregulation, and if we would, in healthcare, anything that makes good business sense is against one law or another.
Yeah. That's
so
absolutely true.
You
just can't do anything logical.
You can't do anything logical. I was into the industry, and I'm like, well, why don't we do this, this, and this? And they say, well, that violates the Knox-Keene Act, or that violates Stark Law. So we can't get any economies of scale. We can't get efficiencies. We can't make systems talk to one another because the different legislative bodies are over-regulated.
I hope you don't take this the wrong way. It's Troy, right?
It is. Well, I love it when people load a question like that. So let me brace myself.
I'm not sure I'm willing to embrace that, your hypothesis that nothing can be done.
Well, things can be done, but they have to be done by changing the system.
There's some question as to whether $2.5 trillion is enough money when we have unlimited demands. the issue becomes balance.
Well, and you know, when you're buying, when we're operating as consumers, we're buying for ourselves things that we're going to consume. As a society, Americans do that pretty well. We don't mind if something becomes 12% of GDP or 50 or 30% of GDP. If it's what we want, we get to have it.
Right.
The problem here is, you know, we think that 17, 18% of GDP on health is a problem because most of us aren't buying it, deciding to buy it, and then consuming it. Somebody else is buying it with somebody else's money, somebody else is delivering it to somebody we don't know. And so, you know, it's sort of a messed up economy.
If one of the trends in insurance today is you're seeing higher co-pays, co-insurance. It's starting to affect patients now when they start requesting things. They're thinking before they're saying, I want these things. And that's a mechanism that I think is working towards helping getting the consumer a little more educated about what it costs. Because right now they're desensitized to what that cost is.
But you see, this health reform is going to undo some of that. As part of these provisions, there's limits not only in how much somebody should have to pay in premium contribution, but also how much out-of-pocket costs they should have. So there's now money that's going to come back to the government to cover part of your deductible and part of your co-insurance. And whatever progress we're making in transparency for a patient, some of that's going to be taken away. And I think when Troy says that the degrees of freedom have been limited by actions of state and federal legislatures, it is true. You can't do some of the logical things because the wisdom of our elected officials is taking away logical ways of letting this thing, you know, work out in a market-based way. And if there's a way to change that, it means we got to go to the polls in the next few elections and bring people in who have a different view of it, I think.
You are absolutely right in that, I'm sorry, my one closing comment. You're absolutely right in that we are great consumers about everything else in our lives but healthcare because we don't understand it and we are completely desensitized to the cost of
There's a
it.
sense of entitlement
Yeah.
that we get everything for free when it comes to healthcare.
Because you don't know any different.
Doesn't matter what the physician does or does not have to earn. Doesn't matter what his qualification, doesn't matter what his education costs, doesn't matter the risk that he's taking, the malpractice, none of that matters.
Ask your neighbors, how much does it cost them to go, how much is a doctor's visit? This is the question of the day. Love this question. I usually talk about this when I speak. How much is a doctor's visit? You know what they tell you? $10.
Right.
How much does it cost, how much is the cost of a doctor's visit? $10. $20.
I agree with you, and I think that the sense in,
What
that's
is
why.
200?
Right,
Okay, so
right,
here's the
and I think
200.
that's something that can be done to educate the consumer.
Well, you know,
yeah, I hate to intervene and
Are we
cut
over?
this off, but I'm
is so
being
exciting.
told that it just seems like it's just.
We're just
ran out of
getting
film.
started, friends. If you want to stay, we're here to talk.
I'm being told.
Wait, hold on. He's taking off his coat. Let me take off my jacket.
There's been a hand up in the back for
Yes.
a long time, so let's take one more question, and then I hope the conversation can continue. Looks like we need some more of these events so that we can continue the conversation. But one more.
This is tough, because I actually have two questions.
I sent this into overtime, but, I guess first question is just, you actually started to touch on it. Do you think that this Healthcare Reform Act will help reduce the amount of fraud that's currently occurring within the system? And number two is, do you think that this healthcare legislation will help educate the consumer to what the real costs are going to be to them, or to the actual institutions practicing what they're doing?
Both are needed. Neither is addressed through healthcare reform.
Yeah, the more difficult you make something, the easier it is for somebody to find a way to cheat the system. And I got to tell you, folks, nobody can understand this.
Yeah. Dennis? Comments?
Well, there's some, you know, as plan coverages are standardized under the law, they're really standardized. They're basically 4 plans for everybody. And there is in the law, you know, what would be an attempt to provide data transparency on what real costs are. So I guess if you're an enthusiast, a health enthusiast, and and these websites are out there that allow this comparative analysis, you'll be able to see, in theory, what things really cost. But like I said, because there are limits to how much you're going to have to financially be involved in the future compared to the trends today, I think that people won't pay a whole lot of attention to it. So maybe a step backwards.
Mm-hmm.
Well, I wish we could continue, but
We do
thank
too.
you very much for your interest.